Hello, my name is Alyssa Miller. I am the Chief of Palliative Medicine at Nemours AI DuPont Hospital for Children in Wilmington, Delaware. And today we're going to be talking about medical marijuana use in pediatric patients. So to start, I think it's important to say that I have nothing financial to disclose, but it's also important to say that I am not a neurologist. For those of you who are interested in a high-level overview of the neurotransmitters and how medical marijuana works in the brain, this is not that talk. We're going to be talking very practically about how families obtain medical marijuana and when we might want to recommend it for pediatric patients. So where are we right now in terms of medical marijuana? So in 1996, California became the first state to legalize botanical cannabis with wide latitude for use. And since that time, in the subsequent 20 years, we now have 28 states plus the District of Columbia who have legalized some form of medical marijuana for adult and or pediatric patients to use. You can see from this map that the majority of states in the United States have either medical marijuana or medical CBD available to patients. These are the most common eligibility criteria among the states, and you can see those highlighted in blue are what's common for our pediatric patients. And so how do patients obtain this product? So the first thing that often happens is a patient or parent will walk into the clinic and they'll ask about medical marijuana. And the first question we always need to ask is, does the child have a qualifying condition under state law in the state where you are practicing? If the child does have a qualifying condition, like the options shown on the previous slide, then the parent or patient need to find a physician who is willing to certify that that patient is eligible for medical marijuana in that state. Once they've found a prescriber willing to certify, they can then take that certification form and they send it into the state and apply to the state registry program, which has fees associated with it, and the families typically have to pay out of pocket. Once approved, the family and the child receive medical marijuana cards. Typically for children under the age of 18, it's a child card and also a caregiver card for the parent. And then they go to the dispensary and buy marijuana. So this is what's very different than what most of us as prescribers are used to. Typically, I am used to prescribing medications for my patients where I tell the pharmacy the exact amount, the exact dose, how many times a day, and for how many days they should be taking the medication. For marijuana, all I'm doing is certifying that this child meets criteria under state law. And after I've done the certification, all of the rest is out of my hands. Families go to the dispensary, they talk to the folks at the dispensary to decide what product and in what amount they should be using for their child and their symptoms. And then they may report back to me at a subsequent clinic visit. But once the certification is done, it's really very much out of the hands of us in the medical community at this point. So the difference between prescribing and certifying, which I think is important, again, prescribing marijuana is illegal under federal law because, as a reminder, marijuana at the time that we are stating this remains a Schedule I substance. And so what we are doing is certifying, which is stating that my opinion is that the patient has a qualifying condition and would benefit from medical marijuana. Often, the certifying physician is not the patient's regular physician. There are plenty of physicians who have set up cash businesses, fee-for-service, where you can come in and for a $200 or $250 fee, talk to the physician, and they will then certify you for medical marijuana. I find that this is not happening as much in pediatrics, that for the most part, our pediatric patients who are using medical marijuana are getting the certification form signed by a physician who knows the child well. And as a pediatrician who often certifies my patients for medical marijuana, I prefer this practice because it then allows me to follow my patients, and if the medical marijuana is useful to them, perhaps I can titrate down on some of the other pharmaceutical substances that they had been using prior to starting medical marijuana. And then legal access is gained only once the patient and family are registered within the state's dispensary program. I'm often asked about how much this is going to cost. Families ask, what is the out-of-pocket cost going to be to them? So the first cost that families incur is the certification appointment cost. That's often covered by insurance. So for example, if a patient or family comes to see me with a complaint of intractable pain, I'm going to do a complete physical exam. We're going to talk about what other medications they have used or tried in the past to manage that pain. And all of that would be covered by insurance. And then if during that visit we talk about medical marijuana and I sign the certification form, the appointment is still covered under insurance. The family then takes that form and with additional family forms, they send it into the state. Cost for a registration card ranges from $20 to $200. You can see an example there. In Pennsylvania is $50 fee. And that is an annual fee that the families are going to have to pay. Every year they're going to need that certification form re-signed, and they're going to have to get an updated card every year. After they've obtained their card, you can see the costs. Cannabis averages about $15 per gram, and for example, for a child who's using it for epilepsy dosing can range from 1 to 30 milligrams per kilogram per day. Total dosing and total cost to family is variable based on weight, dosing, and of course market price. And you can see sort of an average of about $1,800 a year is what a family can expect, but that can range dramatically from $250 a month to as high as over $2,000 a month, which for many of our families may be cost prohibitive unless they live in a state where there is law mandating that insurance covers medical marijuana. So let's talk about the evidence base for using medical marijuana, especially in pediatric patients. How does it work, and when does it work based on the evidence we know right now? The way marijuana works in the body, there are more than 100 phytocannabinoids that have a very complex interaction with the body's endocannabinoid system. And at this time, the endocannabinoid system is not fully understood. But you can start to see an example here, this from Neurotherapeutics in 2015, that this is a very complex system. So when do we use it in pediatrics? Do we use it for pain? Do we use it for non-pain symptoms? What's the evidence, and when might we want to be recommending this for pediatric patients? And do we use it first line, second line, never? Do we keep our recommendations disease-specific, symptom-specific, patient-specific? I think it's important to remember that right now, in 2018, for every disease and symptom, there is an alternative available with better evidence than medical marijuana. We just do not have the evidence, especially for pediatric patients right now, to be recommending this first line. It's also really important to remember that, at least in my field, prognosis matters. So this is a really interesting study published back in 2012 that you can see infrequent cannabis users on the left compared with frequent cannabis users on the right, and then adolescent onset users, again, the big chart on the left, and adult onset users on the right. And what you see is for adolescent onset users with frequent cannabis use at age 38, there is roughly a 10-point drop in IQ from their child IQ to their adult IQ. So if we are recommending medical marijuana for someone who we expect is going to use this daily for decades and starting it under the age of 18, we need to keep in mind that there is an effect on their IQ from childhood to adulthood. So this really does matter, how long a child may be using it and what their IQ is going into starting medical marijuana as a pediatric patient. A recent review from Pediatrics, a wonderful systematic review, was just published, and the results, I think, are really strong, showing that there is evidence for benefit. The strongest evidence is for chemotherapy-induced nausea and vomiting among pediatric patients, with increasing evidence of benefit for epilepsy. However, at this time, there is insufficient evidence to support the use of medical marijuana for other symptoms such as spasticity, neuropathic pain, post-traumatic stress disorder, and Tourette syndrome, especially among pediatric patients. So this is really important when we're talking about making these decisions for minors, for kids who maybe can't contribute to the discussion themselves. And then, of course, everything changes once a child is over 18 and making these decisions for themselves. But again, we need to keep in mind that the pediatric brain is still developing until upwards of age 25 and 26. And so as pediatricians, it is our duty to have these full conversations with patients and families who may be considering starting medical marijuana. So information for patients, there are very few guidelines available. There's little evidence for us to be giving patient counseling, and we need to remind families that this is not a benign product. There is an effect on IQ, and it's not a drug, it's not FDA approved, so there are still minimal dosing guidelines available. But if a family is starting medical marijuana and you have talked to them about it, they meet state criteria, the most important thing to tell them is to start low and go slow. You want families to be starting with very low doses in whatever product they choose, and to go slow as they are titrating up. And once they get to a dose that they think is effective, to stop there, and if the efficacy stops, that they can then continue titrating further. If they reach a point where they've hit any side effects, then you want them to back down to the previous dose before the side effects started. So again, start low and go slow is the message we want to be giving our pediatric patients and their families. So I thank you for your time, and I hope you were able to learn something from this session.